you so much. I'd like to invite the speakers up here as well as our other two panelists. While they're coming up, we'll have a few minutes for questions from everybody, so start your brains going, thinking about what you want to ask. Our first panelist, in addition to the speakers, is Dr. Sanjay Rajagopalan, who is a professor of medicine at Case Western Reserve University School of Medicine and chief of the Division of Cardiovascular Diseases at the Harrington Heart and Vascular Institute at University Hospitals. Dr. Rajagopalan is among an elite group of physician investigators whose work has helped transform perceptions and facilitate understanding of the global development of chronic diseases, including diabetes, and he has made seminal contributions toward the development of next-generation therapeutic modalities and treatment of cardiovascular disease, and is a leading authority in advancing newer and innovative non-invasive approaches for diagnosis of complex CV disorders. He completed clinical and research fellowships in cardiovascular medicine and vascular biology at Emory University School of Medicine in Atlanta, Georgia. Welcome, Dr. Rajagopalan. I'd also like to introduce Dr. Matthew Nenstiel, who is a 2021 graduate from the University of Toledo College of Pharmacy, having earned his Doctor of Pharmacy degree. After graduation, he completed a postgraduate year one community-based residency at University Hospitals, and he's currently our pharmacy champion and clinical pharmacy specialist with UH, with a cinema program. You can see his impact just by getting the applause. His area of interest include ambulatory care and in the treatment of cardiovascular, endocrine, and renal disease. So open the floor for any questions you may have. And I think Jen has a microphone going in the back there. Okay, while you're thinking, I'll get us started. How's that? So I'll open up to the panel. Anyone can opine. What is the biggest challenge to the management of obesity in 2024, and how do we overcome it? Just one single challenge. It's a tough one. Yes.
I would say stigma. I really want to say the drugs cost too much, but I would say stigma, that we are thinking about obesity as being fundamentally different than other metabolic diseases. We know clinically better, but we're still thinking about it that way.
Do you have an idea how to overcome that stigma?
I think overcoming that stigma has to start in the medical community. That we have to learn to be sure to treat all of our patients with deep respect. We have to be sure to. Now there's really good evidence that people that are obese aren't to blame for their obesity, but we gotta feel it and be sure that they know that we feel it too.
Thank you. Anyone else like to weigh in?
I would say
hit the button on top there.
Yeah. I would say it says on. It says on. We'll go with this one. I would say health equity, I think is a major challenge in this day and age. We have the potential to have worse disparities despite having better treatment options, and I think we could be 10 years from now and look back and say we've driven the car into a ditch, and those who have the most resources get the best treatment, and those who don't continue to get sicker. Their greater exposure to the obesogenic environment, and those are the voices that don't have the same level of advocacy and support and help. And I think we could do differently, but it does require us bringing a health equity perspective to all of our discussions in order to do that.
Yes, Dr. Lustig.
I'm going to dovetail off both of them, and I'm going to say that the reason for both of those is this ideology, which we call personal responsibility. So the question is, who invented personal responsibility? Anybody know? Is it in the Constitution? Is it in the Declaration of Independence? Is it in the Magna Carta? Is it in any state house charter? Who invented personal responsibility? The tobacco industry in 1962. They were getting killed on the science, and they had to develop another reason for you to smoke. Well, nobody put that cigarette in your mouth. Nobody lit it for you. Personal responsibility. And the thing is, it worked. And it still works. The fact is, every personal health issue in the history of mankind morphs into a public health crisis when the money gets high enough and the number of lives get threatened enough. And certainly this fits the same thing. And to my point, there are obese newborns basically, do not satisfy the criteria for personal responsibility. So the stigma of, that Dr. Levin-Schertz just brought up and the social equity that Dr. Ard just brought up are actually just two sides of the same coin of basically people saying it's your own damn fault. Obesity is not anyone's fault. Nobody chooses to be obese. Certainly not children. The quality of life of an obese child is the same as a child on cancer chemotherapy. Like, who friggin' chooses that? But you go out onto the street and they'll just tell you, well, that guy's a glutton and a sloth. It's just that simple. Okay? And so I think Dr. Levin-Schertz is right. The medical profession promulgated this. We allowed that to happen. Did we do that for any other disease? Yeah, we did. We did it for a whole bunch until we got our heads handed to us. And it's time for somebody to hand our heads to us now. And the good thing about Ozempic and GLP-1s is that for the first time, there's a window into being able to actually change that idea, that Overton window, based on the fact that, oh, wait a second, all these people who couldn't lose weight all of a sudden because of a medicine can? Well, maybe it wasn't just personal responsibility. So this is something that actually has to be PSA'd all over the country to change, hearts and minds.
Yeah, thank you for that, Dr. Rajagopal.
Sort of expanding, can you hear me? Sorry. Expanding on those arguments, I would say the single word I would use, Ian, is choices. Not just personal choices, but also societal choices. The choices that we make not to reimburse preventive care, but reimburse procedures. And fundamentally, we all know that one of the things that needs to change if you're going to win the battle on obesity is the way we reimburse medical care for individuals. And that single lever in a policy position and how you reimburse the care that you get for lifestyle choices, therapeutic lifestyle management for obesity, non-pharmacologic approaches, which is currently non-existent, would be a huge, positive. But you and I know that that's not going to happen probably for the next 10 years at least. So that's a societal choice. It's also a societal choice, going back to what I find myself agreeing with Robert here, the kinds of stuff that we allow our environment and exposures to happen. It's an unmitigated disaster where you have high fructose corn syrup and environmental chemicals that have been sort of unleashed into the environment, even though we had very good knowledge of some of the health effects of many of these chemicals. And these are ubiquitous in the environment, and that's a societal choice. We can make, we can have a policy position right now to ban microplastics if we wanted nationally, right? And ban all PFAS chemicals, and ban phthalates and bisphenols if you wanted to tomorrow. Societal choice. But again, I do agree with the points made earlier that the stigma that obesity has hopefully is changing, and it's not just about personal choices. We know for many people it has to do with genetics. It has to do with things that they can't control, right? But there is also a personal responsibility where individuals need to take care of themselves, right? And the final thing I would say is, as a society, we absolutely need to address issues of inequities. And obesity is a massively inequitable disease, and the treatments that we provide for our patients are inequitable, and quite frankly, it's unconscionable. And that, again, is a societal choice that we have as a society to allow those most disadvantaged individuals who don't have access to these medications some access to it. And currently, it's just not happening.
I mean, it seems like that we know the science, we know the issues, we know the gaps, but like you said, it's a societal choice, and yet our society is not making those choices. And I don't know if it's the bottom line and the almighty dollar that's driving that, or just, inertia of we've been living this way forever. But, I don't know, that seems to be what everyone's theme is. The one thing is a societal choice. How do we change society? How do we change policy? Still remains to be seen, it sounds like.
Is this on? Yep. And the other thing I would add is, we've heard how prevalent it is, where it starts and where its progression. Where do you expend your scarce resources to start to address the problem? I mean, it is so overwhelming. And it's hard to, it's hard to choose. You have people, you want to prevent it from happening in the first place, but you have people who are suffering. And it's not easy to live with obesity. I have relatives who live with obesity. And making sure that these people who, through no fault of their own, are obese, have the resources to fix or to address their current problem.
As someone who works a lot with lawmakers, what do you think would be the biggest lever for a lawmaker to change their mind and to maybe try to change those societal outlooks?
I think it's already been said. I think they need to hear from the medical community. I think there's a professional responsibility to correct some of the problems that have been created in the past.
Yes, sir.
I'll fix it in one fell swoop.
I love this.
One word that has to disappear from the lexicon entirely. Calorie. Kill the calorie. Hashtag kill the calorie. Because as soon as a healthcare provider says the word calorie to a patient, they have already prejudged that patient to be a glutton and a sloth. Because if it's about calories, then it's about calories in, calories out. Therefore, it's about two behaviors, gluttony and sloth. Therefore, it's about diet and exercise. Therefore, if you're fat, it's your fault. Therefore, any calorie can be part of a balanced diet. Therefore, don't pick on our calories. Don't go pick on somebody else's calories, says the food industry. Bottom line is, the word calorie is replete with onus and innuendo that the medical establishment continues to pile onto patients. If we talked about obesity as a metabolic disease rather than as a thermodynamic disease, we would make enormous headway. By the way, it happens to be true.
Sanjay,
Yeah, I was going to say, one of the things that I find a problem, if you ask me for a policy solution, not that this is the panacea that people are looking for, but it's the enormous influence, at least in this country, that lobby groups have on what we eat and the diets that Americans consume. And it's a massive problem. I mean, the influence that, some of these big agricultural companies hold on, our senators and representatives is not innocuous. It's just massive. And they dictate, and many policy statements and guidance documents over decades, and now we know, are heavily influenced by these companies. And they're massive conglomerates with very specific agendas. And that goes to many of the chemical companies too, the DuPonts of the world, and you talked about the movie. And that's a problem. And how do you address that when you have, just billions of dollars going into the pockets of influencers that are shaping what we consume in our diets and what choices are available to us in terms of, costs for medicines, et cetera.
And if I may circle back to the question about the treatment of obesity, and what I find is the largest barrier to this point, obviously we have all these behavioral modifications, dietary, lifestyle that we try to focus on, but at the end of the day, we still have to treat the patient that's in front of us. And if I had to choose one phrase or sentence that would kind of sum it up, it's medication access and affordability. And so many of the patients that reach us here at the Cinema Clinic or primary care locations or other endocrinology clinics, it's at the end of the day, I think medication cost is what often limits patients in continuing and getting on guideline-directed medical treatment. And so the GLP-1s that we find here today, obviously, as Dr. Levenshire has worked off of, insurers, medical expenditures that are seen with using these medications, obviously is a large expense to the healthcare system and the insurers, but at the end of the day, we have to be able to figure out how to help patients get these medications in their hands, and not just identifying a medication that is going to work overall for the health. So we can choose to put someone on Zepbound or Wegovy or Mounjaro or Ozempic, but it's finding out which of those medications is going to work for that specific patient. A patient may have a needle phobia that Ozempic requires the use of that, whereas something like Zepbound or Mounjaro that has the needle built inside where you take away that phobia for the patient and help them access the medication. And that's where I find my role in being a pharmacist and medication access and helping identifying what barriers reach us. Because at the end of the day, we're going to get patients who are going to have type 2 diabetes, have obesity, but how do we treat them? And for me, it's medication access and affordability.
Thank you. Any questions from the audience? Yes.
I have a question and a comment. So first, thank you to all the speakers. It was wonderful. I'm actually very loud. I don't need a microphone. So it's better for everyone if I don't have a microphone. So my question is, I'm very surprised to hear that the generics are expected to not come before 2027. I would have thought that pharmaceutical companies that are already like very close to being ready to go, given that the patent is expiring this year. So if you can talk about what is the delay. And then in terms of my comments, I think that I appreciated your slide about the cost of this medication versus the cost saving. I think it's very difficult to calculate the cost saving because I'm not sure what went into this calculation. But thinking about the effect of obesity on cancer, was cancer considered? Was osteoarthritis of the knee, physical therapy, and knee replacement? And there's just the development of diabetes that eventually leads to the coverage of GLP-1s for most insurers that cover the medications at the end of the day, people who have diabetes. And then also for employers that provide coverage, all of the non-medical costs that are also involved, like less, potentially less missed days of work, less, you get it.
So I think that this one's probably for me, and
Yes,
so why will it take 3 years for a generic to come out? Well, because there will be a lot of lawyers between the date that the expiration of the patent happens and the date that the first the first generic becomes available, and the generic company needs to get FDA approval. There are many spots where the brand name manufacturer, which honestly, we owe an enormous debt to Novo for doing all the research to show us that these drugs worked. I mean, that might not have happened. So, I mean, I believe that brand name pharmaceutical companies should be able to make a decent profit, but they will. It is a multi-billion-dollar thing to delay for 6 months or for a year, and they will run the clock out every way they can. Clearly, there are ways to make this happen quicker. It happens quicker in other countries. Other countries had biosimilar drugs, 25 of them on the market when we had only 2 on the market. We could do that better. Some of this takes congressional action, and to Dr. Rajagopalan's, I apologize, point. I mean, we have a system where we really desperately need campaign finance reform. So anyway, but that's off the topic. You also said, hey, there must be savings. And, the question is how you're looking at it. If you're looking at societal savings, so for instance, that USC study that I denigrated, they actually gave credit of $1 million for every life year saved. Well, okay, I mean, if we want to do that, then this can look like it's cost saving, but, if you're what ICER is doing is it's just looking at medical costs. They did include a decrement in obesity-related cancers in their, but I do want to emphasize that there's basically, only a handful of things inside the medical care system where we save money by making people healthier. And I'm not sure, I mean, if we're all in agreement that we want to decrease stigma around obesity and that we don't want to treat obesity differently than other metabolic diseases, the requirement shouldn't be that treating people with an effective drug is going to lower costs more than the cost of the drug. It's just we're just not going to get there. And, we might get there if we could get the kind of prices that we could get 10 years later in, a developing country, but we're not going to get there with the prices that we're going to have to pay in the United States and that we should pay.
Yeah, usually lawyers are the problem, so it sounds like the same here.
Yeah.
We're almost at time. I just want to have one more question over here in the back, and then we'll wrap it up.
Thank you, guys. So a question for Dr. Lustig is, according to the map, when it comes to the rates of obesity, we see California, Colorado, Vermont being the states of lower obesity. Also, Colorado and California. I'm sorry?
California?
California was on the map as a lower rates of obesity. No? Maybe certain portions?
Not really. Maybe San Diego.
So I guess then I'm speaking from experience in Colorado, having been raised in the Midwest,
Yep.
With General Mills and Procter & Gamble being the major employers of the state,
Right.
that we that families, generations have been raised upon, and having grown up on General Mills cereal and whatnot, and moving out to Colorado, there are plenty of transplants out in Colorado from these areas. Why do we still see lower obesity rates there than we do in other places?
Very simple. Why is Colorado less obese? That's what you're asking.
Activity,
Why is
but we said,
garbage. Garbage. Total trash. Try again. That's wrong. The reason Colorado is less obese is because of mitochondrial function, because there are 4 things that improve mitochondrial function. Cold, that's why Colorado is less obese. Altitude, that's why Colorado is less obese. Exercise, I mean, I'm not arguing that. And one more, and I'm blanking on it right now. Cold, altitude, exercise, and thyroid hormone, which plays no role in this. Okay, if you take a look at Germany versus Switzerland, okay, they eat the same food. Okay, it's all schnitzel with cream sauce. All right. Germany has a 17% obesity rate. Switzerland has a 9% obesity rate. Is it because the Swiss are more active than the Germans? No. It's because Switzerland is colder and higher. Because the oxygen changes mitochondrial function, increases mitochondrial biogenesis. Because mitochondria matter. That's where you're getting your ATP from. And anything that interferes with mitochondrial function generates obesity. And the thing that is so there are lots of mitochondrial toxins. Ionizing radiation is a mitochondrial toxin, as we learned from all of the astronauts. There's actually a metabolomic study out of Cleveland that looked at that question, in Cleveland, North Carolina. All of these environmental toxicants that I talked about are all mitochondrial toxins. And the biggest one, the one that blows everything else out of the water is fructose, because it inhibits 3 mitochondrial enzymes. It inhibits AMP kinase, it inhibits ACAD-L, acyl-CoA dehydrogenase long chain, and it inhibits CPT1, carnitine palmitoyl transferase 1. All 3 of those are necessary to bring fatty acids into the mitochondria, cleave them into 2 carbon fragments, and generate new mitochondria to be able to burn more. Okay? So the reason why Colorado is less obese is not because of their marketing. That's what it is. It's marketing.
But Robert, you forgot the biggest reason why the Swiss have lower rates of diabetes. They eat better chocolate.
Much better chocolate. Much better chocolate.
Go bioflavonoids.
Could the folks in the back bring up the conclusion slides, please? It sounds like Cleveland has the cold. We just need to build a mountain or something over here. So I just want to take 2 more minutes to, first of all, thank our speakers and our panelists. Thank you. And I'd also like to thank the AJMC and MGH Life Sciences staff, Jennifer Waters, Arya Campana, Daniel Morin, and Ben Baruch. Thank you so much for all your support and hard work in helping this happen. A very special thank you to our Cinema Symposium coordinators, Katie Forrest and Amanda Spino, and some flowers for you guys there. Thank you so much for all your help. I'd like to thank our HHVI and UH leadership, Dr. Mehdi Shishabur, Dr. Sanjay Rajagopalan, Dr. Dan Simon, Eric Hess, Dr. Cliff Majarian, and Sarah Mani. Thank you so much for all your support. And finally, I'd like to thank the cinema supporters and funders who help make our program happen, who allow us to do what we do and to be successful, and we should continue for long from now. So with that, I'll conclude. If you're interested in finding more about cinema or have a referral for cinema, this is our phone number, this is our email address, and hope to see you all next year. Thank you so much. Have a great night.